Hey everyone, welcome to the UNC Neurosurgery Medical Student Primer Series. My name is Shastri. I'm one of the neurosurgery residents at UNC. As part of our primary series, today I'll be discussing subarachnoid hemorrhage. Subarachnoid hemorrhage is defined as bleeding within the subarachnoid space, that is, between the arachnoid and pia layers. This is the space that contains CSF, as well as the major arterial vessels. It can arise secondary to head injury, which is termed traumatic subarachnoid hemorrhage, and this usually is seen with bleeding on the cortical surface, or it can occur as a result of aneurysmal rupture. Aneurysmal subarachnoid hemorrhage is associated with significant morbidity and mortality, as well as prolonged hospital stays and follow-up. The remainder of this presentation will focus on aneurysmal subarachnoid hemorrhage. After aneurysmal rupture, the blood extravasates into the subarachnoid space, quickly spreading through the brain and spinal cord. This can lead to increases in intracranial pressure following the Monroe-Kelly doctrine. The high pressure can cause meningeal irritation as well as directly damage tissues. This can also cause the blood to spill out as subdural, intraparenchymal, or intraventricular hemorrhage. Why is it important to treat subarachnoid hemorrhage? Well, the sequelae of the bleed can be devastating. Upwards of 10 to 15% of patients die before reaching the hospital, and those that survive are at risk of rebleeding and need urgent treatment by either clip ligation or embolization to help secure the aneurysm dome. The blood can cause obstructive or delayed hydrocephalus, which increases intracranial pressures. This usually will require a temporizing CSF diversion in the form of an external ventricular drain or permanent shunt placement. And lastly, vasospasm caused by arterial irritation can cause delayed cerebral ischemia, which is one of the most important causes of mortality and poor neurological outcomes. Taking a second to look at the epidemiology, about 20% of all strokes are hemorrhagic, with subarachnoid hemorrhage accounting for about 10%. In North America, the incidence is approximately 6.9 per 100,000 person years. The mean age is typically described as 50 to 55, with a range of 40 to 60, although this can affect patients at any age, including young adults as well as the elderly. African Americans, as well as women, are known to be at higher risk as well. There are many risk factors associated with aneurysmal formation, the major two modifiable ones being hypertension and smoking, as well as some studies including alcohol consumption as a risk factor. Non-modifiable factors include genetic predisposition. Some of these other listed items that place a patient at higher risk of rupture include history of a prior rupture, having multiple aneurysms, having an irregular morphology, that means having a daughter sac or a bleb, increased size of the aneurysm, as well as cocaine or methamphetamine use. Lastly, infection with septic emboli can lead to mycotic aneurysm formation, which has a tendency to rupture as well. Clinically, patients present with a very acute onset. They typically describe the worst headache they've ever had, sometimes described as a thunderclap headache. Sometimes there could be prodromal symptoms, known as a sentinel headache, which can happen days or weeks prior to the aneurysmal rupture. Patients can endorse nausea, vomiting, signs of nuchal rigidity, photophobia. They can be neurologically intact but have varying degrees of altered mentation, including lethargy, stupor, being obtunded, or even comatose. They can have cranial nerve deficits, focal motor deficits, and also seizures on presentation. Patients typically present to the emergency department after onset of symptoms. A CT scan has a sensitivity of over 95%, with some studies quoting near 100% sensitivity within the first 24 hours after rupture. CTA or MRA are good ways of quickly evaluating for the location of the aneurysm. Digital subtraction angiography still remains the gold standard for finding aneurysms, especially if not seen on a CTA. They're also great to understand and evaluate the anatomy of the aneurysm to help determine the appropriate surgical management. Occasionally, patients can present days after their ictal event, or have low volume hemorrhage not seen properly on a CT scan. In this case, a lumbar puncture can help confirm the diagnosis. These are two images to help demonstrate common CT findings. On the left, you can see significant hyperdensity within the basal cisterns, as well as the sylvian and interhemispheric fissures. This pattern is described in a number of different ways, including as a star or crab pattern, or my favorite is the headless chicken. There's also significant gyral effacement that you can see. On the right, there's blood within the sulci on the right side, as well as significant lateral and third ventriculomegaly, with rounding of the ventricles, as well as some interventricular extension of the hemorrhage. 14 to 22% of subarachnoid hemorrhage patients can have an initial negative angiogram. It is important in this case to repeat the DSA within the next 1 to 2 weeks. Reasons for negative initial imaging include small aneurysm size, vasospasm of the arteries, hematoma, or thrombus obscuring the aneurysm. About 10% of these patients will have a repeat angiogram that is also negative. These are then typically considered paramesencephalic, non-aneurysmal subarachnoid hemorrhages, and typically they have a CT finding like this picture. Those patients tend to have a good prognosis and no additional risk of increased future aneurysmal hemorrhage than the normal population would. There are 2 ways of grading subarachnoid hemorrhage that we use. The clinical grading can be accomplished with the Hunt-Hess or World Federation grading systems. At our institution, we utilize the Hunt-Hess system, which is a measure of perioperative mortality that increases with the clinical grade. The lower grade presents with only a headache, nuchal rigidity, or mild cranial nerve palsies, whereas the grade 4 or 5 can have hemiparesis or be comatose. On the bottom is the Fisher scale. Some places will use the modified Fisher scale. These are 2 radiographic assessments of the blood burden that you see on the initial CT scan. This scale helps predict the risk of vasospasm and delayed cerebral ischemia. After ICU admission, there are a number of ways we medically manage these patients prior to having a definitive surgical management. Some of these measures include increasing the head of bed to greater than 30 degrees to help with drainage, controlling blood pressure through the use of nicardipine or clofidipine drips, as well as using an arterial line to monitor their blood pressure, seizure prophylaxis or seizure management with AEDs. We also aim for normonatremia, euglycemia, and euthermia. Additionally, immediate CSF diversion through an external ventriculostomy may be required if there is significant ventriculomegaly, interventricular hemorrhage, with a deteriorating level of consciousness, because this helps indicate that there might be elevated intracranial pressures. There are a few modalities available to treat these ruptured aneurysms. First is endovascular treatment via embolization. This can be accomplished by placing coils within the aneurysm with or without the use of a stent to occlude flow into the dome. More distal pica aneurysms with redundant flow, middle meningeal artery aneurysms, or mycotic aneurysms can also be treated effectively with glue embolization. These therapies are good ways of treating the aneurysms that are minimally invasive, but they can sometimes leave a neck remnant, requiring further intervention in the future. They also need to be followed with continued and repeated angiograms. Open surgical treatment, although more invasive and with a higher upfront risk profile, can be a definitive treatment. These are secured using vascular clips to occlude the aneurysm at its neck, sometimes requiring multiple clips in different configurations. Aneurysms with a wide neck, irregular morphology, those aneurysms requiring decompression to reduce a neurological deficit, or those that have failed in an initial endovascular treatment can be effectively treated through surgical intervention. Some of these methods include clipping the aneurysm, trapping it and bypassing it, or wrapping it. Lastly, certain hard-to-reach aneurysms may benefit from pipeline embolization, although this carries risk as well, since the patient will require dual antiplatelet therapy in the setting of an acute hemorrhage. And these aneurysms can take up to 6 months to resolve. After the aneurysm is secured, the patient still has significant hurdles to advance. They can be kept in the ICU from 10 to 21 days for vasospasm watch. Vasospasm is defined as narrowing of the arteries caused by persistent contraction of blood vessels, known as vasoconstriction, This is caused by the blood in the subarachnoid space, which irritates the vessels. We watch for vasospasm by frequent neurological checks, assessing for clinical worsening with new focal deficits, as well as CT perfusion showing delayed cerebral ischemia and daily or every other day transcranial Dopplers. Initially, this is managed by blood pressure augmentation to see if this will recover a clinical deficit. But if it persists or is no longer responsive, the patient may require additional endovascular treatment with intraarterial rapamyl or milrinone. We can also administer intrathecal nicardipine through an external ventriculostomy for 3 to 5 days as well. Once secure, the risk of rebleed of the aneurysm is low. So at that time, we increase blood pressure goals to help with perfusion and remove any seizure prophylaxis we had initiated. If an EVD was placed, we work to slowly wean it, watching intracranial pressures and the neurological exam until we can safely remove it. For some patients, they become dependent on CSF diversion and they require permanent ventriculostomy. Depending on the severity of the neurological deficits, a lot of these patients will need other interventions such as a tracheostomy, G-tube placement, and even further rehabilitation after discharge. So, in conclusion, aneurysmal subarachnoid hemorrhage is associated with significant morbidity and mortality, as well as lengthy hospital stays and increased healthcare expenditures. Patients present typically with the worst headache of their life, altered mentation, and possible neurological deficits. It requires urgent endovascular or open cerebrovascular intervention within about 24 hours to prevent risk of catastrophic rebleed. They may require temporary EVD placement or even permanent shunt placement for elevated ICPs and hydrocephalus. And lastly, even after the aneurysm secured, they require close ICU monitoring to prevent vasospasm and delayed cerebral ischemia, as this is associated with having improved neurological outcomes. Thank you.